This year is the first year we have opened up the forum to all interested health systems. For those of you who are joining for the first time, welcome and thank you for being here. We hope you will find the forum stimulating and useful. I'd also like to point out that today's session will be recorded and made available in the archived events page on Learn's website. So please share that information with colleagues who were not able to make the event today. I'd like to thank our funders, the National Center for Medical Rehabilitation Research and the National Institute on Nursing Research. I would also like to thank our Forum Planning Committee, who helped us develop this year's Health System Leadership Forum agenda. So thanks to all of our committee members. I would now like to introduce our keynote speaker, Lynn Brady Wagner. I'm delighted and honored that she's here with us today. Ms. Brady Wagner serves as the Chief Learning and Diversity, Equity, and Inclusion Officer, the Chair of the Ethics Advisory Committee, and the Associate Director of the Spaulding Stroke Wellness Institute at the Spaulding Rehabilitation Network. In her 26 years at Spaulding, she has fulfilled many roles, including speech-language pathologist, Director of the Stroke Rehabilitation Program, and Director of the Clinical Scholars Program. Ms. Brady Wagner is a faculty associate of the Harvard Medical School Center for Bioethics, an adjunct clinical assistant professor at Massachusetts General Hospital Institute for Health Professions, and a lecturer at other local universities. She has numerous publications in peer-reviewed journals and has presented nationally on the topics of stroke rehabilitation, ethics, and disability. She also serves on the editorial board for the journal Topics in Stroke Rehabilitation. Ms. Brady Wagner has been consistently active in several professional organizations, including the American Congress of Rehabilitation Medicine and the American Speech Language Hearing Association, where she served on the Board of Ethics and as coordinating committee associate chair and chair for the Swallowing and Swallowing Disorders Special Interest Group. She has also been involved in clinical and professional committees and projects for the American Heart and Stroke Association. Ms. Brady Wagner holds a master's degree in speech-language pathology from St. Louis University, a graduate certificate in healthcare ethics from Rush University Medical School, and was the first Disability Ethics Fellow at the Rehabilitation Institute of Chicago, now the Shirley Ryan Ability Lab, and the McLean Center for Clinical Medical Ethics at the University of Chicago. She is certified by the American Society of Bioethics and Humanities as a healthcare ethics consultant and by the American Medical Rehabilitation Providers Association with a medical rehabilitation management certification. Lynn is committed to continual improvement of the quality of clinical programs for people with disabilities and to supporting the professional and personal growth of our workforce. Thanks so much for being with us, Lynn. We look forward to your keynote.
Thank you so much, Janet. I'm so happy to be here, and I have a lot of slides, some of which are just informational, and I'll blow by, and we'll stop and talk about a few things. But I'm really thrilled to be here today. I'm going to share my screen, and we will get started. Today, I'm going to focus on, I just think that these forums are such a phenomenal resource for all of us and an opportunity to have a learning network and share the different programs, activities, and structures that we've put in place in each one of our institutions, all with our goal of moving toward learning health systems and being able to have solid understanding of the data and the outcomes of the work that we do. So today I've titled my talk, Data Accessibility, Structural Empowerment, Inclusion, and Logistics. I'm going to be focusing heavily on the structural empowerment component. And just sort of an interesting side note, I have a cousin, Major General Jeannie Leavitt, who was the first female fighter pilot commissioned by the Air Force in 1993. She just retired from the Air Force, actually effective on Sunday. And I was at her retirement celebration this weekend, and she was talking about lessons learned in 30 years of leadership in the military. And a leader being, from the very first moment she began to train and she began to work to collect data to understand how the plane worked, how the teams worked, et cetera, et cetera. And she emphasized that, you know, we have a lot of really great, expensive tools that we use, but the most important component of the weapon system and the most important source or receptacle for our resources and our attention should be the human involved in that, because the human person is the most important component of that weapon system. So we're going to talk a little bit today about structural empowerment, which focuses on the human beings in our midst, in our organizations. Just a very little bit. I know Shonali Guadino, if you were able to watch last week's presentation by Dr. Shrivastava, which was absolutely phenomenal and informative. And just by the way, a shout out to Intermountain Health System for the great work that they do, which has informed work and structures that we have in place here and in Mass General Brigham and in the Spalding Rehab Network. And also to say you are getting very soon a phenomenal leader in your ranks, Bob McCall, who is my current supervisor and is leaving here very soon to become the Vice President of Rehabilitation Operations for the Intermountain Health System. So very excited for him and for Intermountain and for our continued learning from one another. So Spalding is a member of the Mass General Brigham Large Health System. We are a key part of the non-acute or post-acute arm of that system. We focus, of course, our values and mission focus on patient care, teaching, research and discovery, community, and equity. And I would say that, you know, there are very distinct departments and structures related to patient care, and then separately for research and discovery. So part of what I'll be talking about is how we help support the individuals who are in the patient care component be able to be involved because many people come to work in all of our institutions. The clinicians who come to work here have an interest in participating in research, but that may not be what they were hired to do. They're hired to take care of patients. So how do we create structures that will allow them to do that, allow them to have autonomous and leadership participation in the areas of research and innovation? This is just a description of the network that we have in terms of our physical buildings and organizations. We have 2 IRFs, 1 skilled nursing facility, 1 long-term acute care hospital, and 25 outpatient sites throughout Eastern Massachusetts. And you can see here that 2 of our inpatient facilities were recognized with the Magnet designation. So becoming Magnet, and then 2 are on the journey to Magnet, which is, for those of you who may not know, many of you do, of course. Magnet is an American Nurses Association designation that gives the highest level of recognition for quality in an organization, and that they have the systems in place to support clinicians in that institution to be able to participate in quality at such a high degree that it allows the clinicians to feel magnetized to the institution, that can recruit other nurses of high caliber quality who want to participate there, and that they will then retain and be a part of those positions. So that creates the magnet to the organization. Again, sort of just another overview of our Eastern Massachusetts 25 outpatient centers. We often say from Cape to Cape, Cape Cod to Cape Ann, with many different specialties in those organizations. And we have in our outpatient organization a structure in place called our special interest groups. And these are groups of clinicians of all disciplines, although mostly for this group, focus on our outpatient, where they come together and share resources and create standards for the care of individuals in certain diagnostic groups or for particular kinds of interventions. So we have a lot of knowledge sharing there that we pull into the programs I'm going to describe. We are very fortunate to be recipient and fiduciary steward of 3 model systems currently: the burn model system, the spinal cord injury model system, and the traumatic brain injury model system. But I would say, of course, you know, we're not perfect. We are on the journey, and actually both journeys here. One is that we're on a path to try and continue to create a true learning health system where at every level of our organization, we're constantly researching, creating programs, doing an intervention, evaluating, reframing, and doing that again. We know that it is a winding road, that there are hills along the way, but we will continue to have our mantras, don't stop believing. We will get there. I can't hear any laughing. I hope that you are chuckling there. You know, we want to thank you for the heart. We want to figure out, you know, how we could connect with, you know, this learning journey to become a learning health system, ascribing to, of course, the important values and vision of the Agency for Healthcare Research and Quality in describing the learning journey. And as I mentioned before, we had sort of 2 separate working groups. We have our clinical working group that provide the care and that meet the regulatory requirements of each one of our different levels of care. And then, of course, we had our researchers and our academicians who are working, who have both the training at a high level with a PhD, an MD, et cetera, as well as the funding to create that space for their position. But we have many clinicians. We have a lot of data. We have a lot of work that we could catalyze to help understand better how to take care of our patients and really feed the weapon system, as I was describing before, our clinicians who are very interested in this and who can provide support for these efforts. So, you know, I'm going to be describing a program that we developed and continues to this day. I'm going to describe some of the tools we use to support clinicians in that program. And all of this falls under the definition of structural empowerment. Structural empowerment is a term, a concept that was made, put out there and popularized by Professor Cantor, a Harvard sociologist, in her book, Men and Women of the Corporation. And she indicated again that people are the most important resource, that we need to empower them in order to fully maximize their potential. And empowerment equals access to resources, opportunity, information, and support. That top-down is less effective than providing the opportunity for smart, autonomous, capable, caring, compassionate, interested individuals to create solutions that help the problems that we're facing. Again, here, a recognition of the Magnet Recognition Program in their adoption and sort of prominence of the tenet of structural transformation in one of their 4 key or 5 key components of what makes a magnet organization. Part of that, another component, is transformational leadership. And I will say it takes transformational leadership to envision how we can support and create the structural empowerment to allow staff to access the data, to figure out how they can use their time in the clinic, in their work environment, to move these things forward and to be a part of the change in the learning health system. So this is probably my biggest descriptor slide of the program itself. I'm going to be discussing here an effort that we put in place about 13 years ago called the Clinical Scholars Program. We have this program in place that helps clinicians at all levels of the organization engage in scholarly work to help them promote the ideas that they have, the opportunities that they see in the clinical work that they are doing, help them to access the resources, the structures, the education that we have available to do the work, and then importantly to help them disseminate that internally and through extramural dissemination at conferences, publications, presentations, et cetera, et cetera. So I'm going to be talking today a little bit about what the Clinical Scholars Program is, who it's available for, what the structure is for that. I'll be also referring to this middle part. What are the supportive programs and methods that are used to support the clinical scholars themselves? And then how are we supporting their internal and extramural dissemination? Individuals in our organization, this is a fully interprofessional opportunity and program. We have indicated to them that if they would like to submit a presentation to an extramural conference, that they should apply to the Clinical Scholars Program for 3 reasons. One, initiating the application ensures that they've had a conversation with their supervisor to discuss the opportunity and to receive approval and any kind of discussion they need to have about their time, et cetera, et cetera. Secondly, that we then know about it and are able to meet with them, talk about the project, and support that project based on what the scope of it is, what their idea is, what they'd like to do, and what programs we have available in the system, methods, networks, et cetera. And that includes what kind of data do we need? What kind of data do we need to capture that we don't already have? And if it's data that we do have, where do we go find that data? And then thirdly, to recognize those who are doing this work and to celebrate them. The middle section here, again, are the supportive programs, and I'm going to be talking a little bit more about each of them. The first is a fantastic program that was developed about 8 years ago for the Spaulding Rehab Network, and this is called the CLIP program, or the Collaborative Learning Improvement Program. This is our formalized process improvement program, where periodically we'll come together, bring together interprofessional teams who will work on an identified quality project for a particular unit or for a particular institution. And that project goes through all of the components of quality improvement. We'll talk about that in a little bit, but it allows people to go through and learn a process for PDSA cycle, for identifying an aim statement, a problem, identifying the intervention, and being able to evaluate that in a way that is effective and accurate. The Clinical Process Improvement Leadership Program, that's this one right here, is what is run by MGB, or our parent company, and that is just a little bit more high-level type projects that have a little bit more in-depth training and intervention around that. You know, the CLIP program is sort of just-in-time training. CPIP is learning a little bit more of the tools and foundations, and we use information from Intermountain foundationally in that program. The second 2 programs are really new programs that will be wonderfully supportive and help us to expand this work. One, you heard from Shonali Gaudino, who is a colleague and the executive director of the Rehabilitation Outcome Center for Spaulding, with the ROCKS program, and she's doing phenomenal work, really connecting again our big tranches of rehabilitation research and clinical care. How can we bring those teams together and find opportunities for cross discussion, dissemination ideas? And then finally, we have a newly developing nursing center for research and innovation, and our evidence-based practice fellows, the Nightingale Fellows, that really focus on the value, knowledge, and skill and important clinical experience of our nurse group. The internal and extramural dissemination occurs. We have an internal once every year relatively, although COVID kind of threw us off with that. And then any extramural dissemination, people are supported with materials for PowerPoints and reviewing posters and making sure we've got a process for internal review of all of the presentation materials to ensure that we connected to all of the programs that we're doing across the system to help people grow in their skill in doing that. But importantly in that, we need to have transparent policies for continuing professional development and conference attendance funding. So as somebody comes into the Clinical Scholars Program, that's also a very important discussion that they have with their supervisor. What kind of carve-out time is available? That depends on the project, although generally we have, 1 to 4 hours once a month. And then assuring that if the person comes and would like to present it at a conference, that we know from the get-go if that will be able to be supported. For example, if we've got 10 speech-language pathologists who come forward and say, I'd like to go present at the Pediatric International Seminar in London next year, all 10 of us, there's going to be a conversation about the limitations of our ability to fund that presentation. So let's talk about the Clinical Scholars Program. 13 years ago, I was tasked with ensuring that we had a more prominent, robust opportunity for clinicians to participate in clinical research. And also came with that sort of our connections to our academic partners. And Spalding, as part of the Mass General Brigham system, and actually geographically positioned right down the street from the MGH Institute of Health Professions, and the MGH IHP, therefore, is our most closely associated academic partner. And so we have had over the years opportunities for faculty from the IHP to come and give talks. And so when we sat down and began to envision a program that could be used to really help people follow through on and practically execute quality studies and research studies, we talked together, and Leslie Portney, who was the director of the PT department, then became the dean of the Rehabilitation Sciences department and had written the book on methods of clinical research design, said, I could come over and give another 45-minute talk at lunch, but let's think about a program that we could develop where we put in place structures that allow people to complete projects. And that is what we did. This is, again, I am here as a representative of a team, many people, many programs and many teams. But this is just an idea of the inaugural group who worked on that. And the program goals of the Clinical Scholars Program are to foster and support the training and resources needed to empower staff members to practice as clinician scientists. For the purposes of specific discrete projects, as well as just in their regular work that they do all the time. Secondly, to facilitate academic activities among clinical staff members, and finally, to promote participation of our clinical staff as faculty and presenters at national and international conferences. Just got to get on the right page there. Great. And it came at an interesting time because we had literally just gone live with Meditech, which is a electronic health records system. We now use Epic at Spalding and through all of MGB, which allows us much greater power of data. But at the time, this was huge. We had never had that opportunity before. And if anybody wanted to do a project that collected a large amount of data, you usually first needed to have an IRB and a project that had a database that was created for a particular program. So we were really excited about the opportunity because, of course, finding the way between what is really excellent, high-level, high-value research versus what kinds of practical projects we could do and execute and complete is always a tension, especially for people whose job is not solely tied to completing research. So this is an opportunity to create projects to ask of the data system that had greater power because of the numbers that we were able to pull from that data. So this is just a picture of that first cohort. You actually see Shonali Guardino here, she was one of our first cohort members, and it was very successful. We do an internal presentation where people at the end of their project present to a large number of individuals in the organization. So we started the Clinical Scholars Program. Actually, I'm just going to go back here to this slide. here. We started the Clinical Scholars Program with a specific curriculum. We had people apply from all throughout the organization. They then met once a month, and they went through a series of trainings that allowed them to learn about the process of the IRB, learning from the IHP librarian about how to use OneNote and how to do clinical research searches, learning from the faculty at the IHP of how to formulate a research question. So we had a very structured curriculum for the first 3 years. Then we shifted after that to supporting ad hoc individuals, either individually or in small groups, to be able to access that information. And so now I'll go back to this. One of the things that we have done since I took the role of the Chief Learning Officer here is to create a SharePoint communication site that helps to provide information to staff about all kinds of learning opportunities. One of those learning opportunities actually is the Clinical Scholars Program and a virtual curriculum of how to perform scholarly work, research studies, and quality studies. So all of that is found on this education and training site, which we have also linked to our performance evaluation. And again, part of structural empowerment, linked it into a recommendation for staff members to think about their goals, to think about professional development, and to link to that site to find opportunities and talk more with their supervisor and with program directors. In that site is linked specific information, as I was just mentioning, about the Clinical Scholars Program. It describes an overview of the program, talks about the goals, and has a link to an application form. The application form is filled out by the clinician or a team of clinicians. It's sent in a direct email to me. I send it to their supervisor, and there's a note there to say you've discussed this with your supervisor. Who is your supervisor? I send it to their supervisor to assure that they've had that conversation and that they approve of their participation in the program. And then we talk about the ideas that they have, the challenge that they're looking to fix or to solve or to study, and we talk about the right kind of resources. This is that site that has the virtual curriculum with all kinds of tools and information about, evidence, writing a paper or a presentation, research processes, scholarly work, how to get the data, etc. And then this is more of that site, lots of different information that those clinicians can use and will help guide them based on the type of question and problem that they have. And then here on that site is an opportunity for new clinicians to come in and see what kinds of programs and projects have been done in the past. And so there's a list of all the different Clinical Scholars Group and examples of posters that have been presented. This is one poster that was presented by, and I promise I'm not being biased to speech pathologists. It happened to be the one that that came up that I think is really applicable to our discussion. But Rebecca Foote, former speech pathologist here, looked at our FIM data a number of years ago. And that has helped clinicians be able to have prognostic conversations with new patients. As she understood from a subject database of about 2,000 patients who have come to us with initial expressive language issues, depending on where they were, what FIM score, which I know we don't do anymore. We'll need to, of course, do and recalibrate with our new scores and tools. But if they came in at this level, what percentage probability would they end at this level, and how could they describe that functional level that they may be moving toward? So using the data as a tool and really thinking about how we can translate it very specifically and importantly to help our patients understand their recovery and prognosis. The Clinical Process Improvement Program, the CPIP, which is one of the methods of supporting staff. So say a staff member comes through and they have a project that would fit well with the CPIP program. We might encourage them to apply, and this is a very structured curriculum that they can go through. My partner in nursing, the nursing director on the floor when I was the stroke rehab manager, we did a project focusing on discharge process satisfaction. We used the tools of CPIP to help us and the team design and understand what the challenges were for our process improvement using tools of quality improvement. This helped us teach not only ourselves, but our entire team how to approach projects and problems like this, gathering diagnostic data, understanding our baseline. And what we did was we decided to measure the number of times when families actually participated in a program we call the Family Participation Day, which helps them come in and have one-on-one discussions with the clinicians of the patient's team and really understand where are they now, what is our estimation of where they'll be when they're ready to leave the hospital and what we're looking for along the way for improvement. We found that that was low, and so we put in place an intervention so that we could increase that to help families come in, to help have those conversations one-on-one with the clinicians as opposed to sitting down in a room and talking about status, but really bringing people in, watching the session and doing active learning there. Again, using many tools to understand what would be the best intervention and how do we measure that, and then coming through and seeing that we went from, a very low average of percent times that people came in to this Family Participation Day to putting in an intervention that helped us raise it, and then another one that helped us sustain it. And then the second program, which is a really important program that we have, is run by my colleague, Deborah Blythe-Wilk, who is an amazing expert. She's a nurse. She's a lawyer. She has her JD. She is the former vice president of quality and safety, and she is the new executive director of nursing practice in the Spalding Rehab Network. And she helped to develop the CLIP program, which is basically the CPIP program for Spalding. And teams are brought together to address identified issues, mostly by administration. So it may be less coming from the clinicians themselves, but everybody who's on those teams are really involved, frontline experience with that. We also do ad hoc programs and problems, one of which resulted in the Brain Tumor and Serious Illness Task Force in our institution. And when we have these ad hoc programs where there's not running a program, a formal curriculum for CPIP or for CLIP, we run them through the same kind of tools and methods that are used in those programs, and they connect with those people. So for this group, we identified that there was a significant rise over the last, and we did this project about 3 or 4 years ago, and the 3 years prior to that, we had a significant rise in the incidence of new onset brain mass for patients we were seeing in our neurological units. And there were specific issues that were different from patients with traumatic brain injury that we needed to be aware of and that we needed to try and address. So we came up with based on doing an analysis, we came up with the Brain Tumor and Serious Illness checklist. And then we did a quality improvement process to implement that clinical checklist to help people use it in the interdisciplinary team rounds and make sure that we were planning for anticipated needs of this particular group to help avert response in a crisis. Now, I know I just have like 2 seconds left before I know we want to get to some questions. So that is really sort of an overview of our clinical scholars program, which continues. We have people who are invested in this. They apply to the program. We want to make sure that it's understood by their supervisor, that there's a discussion on how we can support them financially with protected time and with the resources at the institution, that we put them in touch with all the right resources. If say they're a person who wants to study or look at problems with certain patient population in one of our institutions, yet there's another large program in one of the other settings that they don't normally interact with, will make that connection and make it part of their project and their protected time to have those collaborations. And then to help them with dissemination internally as well as externally. But the thing that I also want to mention is that as we think about these projects and programs, we want to make sure that we have an equity lens to this. And as we think about the data, and very fortunately, Deb Murphy, who is my close colleague, will be presenting on the ways that we've been trying to create opportunities to evaluate data in a in a way that looks at the difference in identity and how that might impact the outcomes or the information that we're looking at. Here at Spalding, we use the terminology DEIA for diversity, equity, inclusion, and accessibility, taking a nod from the Biden administration in 2021, who asked that the workforce use this terminology to include accessibility. I'm very excited and happy that yesterday the NIH reversed an initial, I think, misguided decision for which they got a lot of feedback and advocacy, where they are now going to include disabilities as a health disparity in population health research, so that those kinds of studies will count, which we're very happy about. So this is just a reflection of our Health Equity Steering Committee and the kinds of data and the kinds of points that we are looking at internally in response to the Joint Commission standards, the CMS standards, and our internal processes, including, of course, our census identity data, our outcomes data, our quality metrics, health-related social needs, how effectively are we capturing that, patient experience surveys, safety occurrence reports, our ADA compliance rounds, FLIP and CPIP, and organizational ethics situation analysis, such as equitable holiday scheduling, which is something that we had done internally recently, and employee experience, which we have a survey active right now, and we're really looking forward to understanding that data. And then finally, in closing, I will just say, some lessons learned is that we need to continue connection, communication, and inclusion as we have new leadership, as we have new clinicians. We need to reinvest and remind people about these programs so that they can access them, and we can have saliency of our resources and capitalize on our resources for our most important components, our people. Leadership support is critical. Connect with our colleagues, create allyships, and keep equity at the core of decisions. Logistics are critical. How are we doing this? Do we protect time? How are we creating transparent policies of support so everybody knows how we make decisions to send or not send somebody to a particular conference or course? How are those decisions made, and how are they made equitably with a view over the entire system? And we have a clinical ladder in many of our clinical departments, so participating in some of these activities, in addition to having some known protected time and support for attendance and travel costs for a conference if they're accepted, it's also to contribute to work toward their clinical ladder, which can lead to some financial change. And then sustainability, of course, so we've all talked about that in these sessions, which is, I appreciate knowing what a challenge it is for all of us, because it is a challenge, but we want to continue to create opportunity for our staff and understand our data sources and the benefits and complexities of this electronic rich data environment. And thanks to Deb Murphy for her discussion very soon. And we want to investigate, evaluate, share, and pivot as we need. And then I'm shared so resources here, and then I will stop my screen share, and very happy to have discussion, questions, and of course would love sharing of the kinds of, because I know that we didn't create something that is completely unique, but want to know how this may work in your organization. How are we getting down to the level of our staff? Thank you very much.